Hello, and thank you for joining the POCUS Certification Academy for today's POCUS Bites webinar. My name is Tiffany, and I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments throughout the webinar. Today's topic is the ins and outs of adopting POCUS in primary care practice, and our speaker is Dr. Tatiana Haverlek. Dr. Haverlek is an emergency physician, formerly ultrasound director at the Brooklyn Hospital, and founder of Hello Sona. Throughout her 15 years of clinical practice, she has relied on POCUS to make informed clinical decisions, whether it was in an urban ED, urgent care, or Everest Base Camp. Dr. Haverlick is now on the mission to extend the benefits of POCUS to primary care and urgent care practices, as well as rural hospitals by addressing the key barriers, lack of POCUS competency and infrastructure. Let's welcome Dr. Haverlick.
Hello, everyone. I'm so happy to be back with the POCUS Certification Academy with all of you here today. Should we get started?
Let's get started.
All right. And I would
Thank you.
love for our attendees to just type in where you're joining from, the city, the country, and also, are you currently using POCUS? Well, welcome, everyone. And I'm loving to see the diverse group here, and let's get started. All right, the roadmap to success, the ins and out of adopting point-of-care ultrasound in primary care practice. Um, I have a little bit more of an intro about me, but I'm not going to dwell on this. More as Tiffany already said, I'm an emergency medicine physician, but I have also completed fellowships in point of care ultrasound, and I actually still started in wilderness medicine world. So I was involved in quite a few global health projects, including working at Everest Base Camp during the climbing season. As she mentioned, well, I'm not going to repeat any of that. But I managed an ultrasound program for an emergency medicine residency at the Brooklyn Hospital. And that's where I really identified a lot of gaps and need for administrative support for other departments, including family medicine, internal medicine. And that's kind of the idea of a Hello Zona started. So I'm super happy to be here today. And just wanted to let you guys know I'm very much passionate, not just POCUS in medical education, but dark chocolate and most recently pickleball. So type in kitchen if you are on the pickleball journey. I'm just gonna. Oh, Cameroon. Welcome. Okay, I don't see anyone typing in kitchen. So I guess there are no pickleball nerds like I am. All right, moving on. And today's agenda, it's actually pretty brief. We're gonna kind of talk over some important considerations before you start implementing POCUS, and then I'll give you the roadmap. We'll talk about some tips for success and have some questions for Q&A. And I saw some hearts flying, so I do think there might be some pickleball fans here. So let's consider these six concepts before we start, while we're, as part of our presentation, excuse me. So the usability of POCUS in your practice, provider engagement, the right devices and workflow, quality, compliance, and revenue. Ooh, what's going on? So let's start with usability. Is it right for your patients, your patient population and your practice? So some things for consider is what are you going to be using it for? Right? Is it the ruling out maybe DVTs because you're seeing a lot of patients after hours? Do you have a large patient population with congestive heart failure and you would like to keep them out of the hospital and you would like to monitor fluid status and adjust medications in the outpatient setting? So kind of lots of things to consider. Or are you in the orthopedic practice, or maybe you're doing a lot of sports medicine type of visits and you would like to have POCUS more for procedural guidance and some maybe diagnostics in musculoskeletal realm. And another thing to consider is what problem are you solving? And that really applies to, for example, maybe you are dealing with patients who are not likely to follow up with imaging in the future, or, just don't do very well with consistent healthcare follow-up. So this is your chance to really kind of, when they come to your office, to do everything you can for them to ensure that they are safe and healthy. Another problem you might be solving is access to imaging in general. So for rural settings, this is really a big deal, but even in urban settings, access to imaging can take a couple of days to get, for example, an ultrasound. And I'm actually joining you from New York City, and we do have an issue here of not being able to arrange prompt follow-ups for the patients. So once you kind of figure out, okay, clinically it makes sense. I think my patient population will benefit from POCUS. You're kind of ready to brainstorm the next topic. Um, and here I just wanted to share some high yield use cases in primary care in case you're still kind of new to figuring out where POCUS could fit in. So you can use POCUS for evaluation of patients with like swelling and pain, to look for DVTs, to rule out CHF exacerbations, soft tissue complaints, looking for cellulitis, abscess, foreign bodies, any patients with respiratory complaints, right? POCUS is great at ruling out pneumonia, pneumothorax, CHF exacerbations, diagnosing COVID. So all of those applications are super useful in primary care, where hopefully you can avoid sending patients to get a chest X-ray, for example, and delaying their treatment. Patients with flank pain or hematuria, if you are concerned for kidney stones, you can look for hydronephrosis with POCUS. Also, anyone with kind of suprapubic pain, difficulty urinating, you can measure bladder volume to evaluate for urinary retention. Patients with abdominal pain, so POCUS is great for abdominal aortic aneurysm screening. You can also look for ascites in your patients with liver disease or CHF. Patients with epigastric pain. So ruling out cholelithiasis, cholecystitis could be really beneficial if you do it at the bedside, and hopefully avoid sending your patients to further imaging and increasing the costs of their care. Musculoskeletal injuries, those are really big right now in primary care. Mostly looking for kind of tendonitis or any kind of maybe acute or subacute injuries of the tendons and ligaments, but you can also look for joint effusions, muscle hematomas, and even fractures. And I know it might be a little bit out of the scope of primary care, but definitely something you can start with and then get a confirmatory X-ray if you need to. And of course, procedural guidance, is it either it's placing an IV or just getting a blood sample in a difficult patient, or performing INDs or any kind of joint aspirations, paracentesis, foreign body removal. And of course, there's also screening for CHF and abdominal aneurysm. So there's so much more, so many things you can do with ultrasound in primary care. I would just warn you not to do all of them at once. So pick maybe 4 applications to start with, and then you can always build on it. All right, moving on. Provider engagement, super important. So if you are part of a bigger practice and you're looking to introduce POCUS, you really need to have your providers on board with us. So do they really believe in POCUS? Do they think it would be useful for the patient? Would they even use it if you train them? So that's question number 1. If they are not quite on board, maybe it's better to start with educating them of what's possible with POCUS before you have them kind of being forced into training with POCUS. And another thing to consider is, will the providers commit to the training? Because the training path in POCUS is actually quite long, right? And we'll cover this in a little bit, but it might take 3 months to a year to actually develop competency in POCUS. So it's not just taking, one online course and maybe hands-on course, and then you're done and you can start diagnosing your patients with POCUS. The journey is a bit longer. Other considerations, and this is also really important, is having the right devices and the right workflow for yourself and your providers. And that even picking device, what device features are important to you? Would you like a really portable device, like a handheld device that's maybe wireless, or do you want it wired? Does it need to work with Apple products and Android products, or do you maybe you'll have just Apple devices and that's what you want to stick with. But connectivity piece is really important as well. What's your budget? What kind of probes do you need, right? So, and that depends on what kind of exam types you're going to be performing for your patients. Do you need a really high definition linear probe, high frequency linear probe, because you're going to be doing a lot of procedural musculoskeletal ultrasound? Well, that kind of changes what device you're going to get. And then the cool thing right now is the AI features, right, of these devices. If you have a lot of novice users, you might want to invest into devices that have a lot of AI features for guidance. Hey, this is the way to get a better view. Move your probe this way. AI will actually tell you this. And it can augment the diagnostic, kind of the interpretation capacity as well. And in terms of storage. So how will you store those exams? If you're planning to make medical decisions on POCUS, if you're planning to bill for POCUS, it's essential that you store the images and clips, right? And it just protects you medical legally. It is part of the medical chart, and you need to figure this out. You know, it has to be a HIPAA compliant storage. Ideally, you want indefinite storage. So, you know, what's your budget for that? What's available? Maybe there's something that's available internally if you're already a part of a bigger healthcare system. And this is kind of what I mentioned, like what's available, but also what's preferred. So also if you are part of a bigger system, talk to your IT, so IT and biomed, and see whether there are already preferences in your institutions. Because sometimes sticking with a workflow that, for example, emergency department is already using, you know, for their archiving of POCUS imaging might be a lot of a lighter lift than trying to introduce a new software or a new cloud storage into your practice. Next is considering, you know, how are you going to maintain quality and ensure quality of your POCUS program? So what is going to be your path to competency? And we'll cover that a little bit, but there are standards that exist for providers to develop competency in POCUS, and they are based on American College of Emergency Physicians standards, AAFP, so the family physicians now also have standards. So just be familiar with those, and I'll cover more on that later. But defining that for your clinic or your practice based on the resources you have and also the use cases you're going to be using this POCUS for is really important. Um, and then think also, how are you going to maintain that quality? What's your quality assurance process for POCUS? Are you going to have radiologists read some of the studies to ensure quality? Are you going to have internal review? Are you going to have external reviewers as well? And I think another important thing to consider in terms of quality of assessing how good your program is having some data. Right? Are your patients liking the fact that you're getting POCUS? Are you becoming more efficient? Are you bringing in revenue? So all of those things really also tie in with quality of your program. Compliance kind of goes hand in hand with quality. Super important when you first start is to have protocols related to to POCUS. So what is your infection control protocol? Are you doing procedural guidance? Are you going to have sterile gel and probe covers to follow the basic standards in infection control? What is going to be your credentialing protocol? If you're a part of a bigger clinic, are you going to let providers bring their own devices? Right now, there are so many handheld devices that you can just purchase and scan the patients in your clinic with personal devices. So all of that, it's really best if you write it out and might make it a standard and share it with your team. So it's really clear. And then, of course, compliance ties in with storage. So you are required to have HIPAA compliant storage if you're planning to to bill for any of your exams. And I know quite a few of you are also international, so maybe that wouldn't apply for you, but still for medical legal protection and just record keeping, it's a good idea to store the images that you obtain. And of course, going back to competency, right? Are your providers competent? Do you have a Q&A process in place? Oh, not a Q&A, quality assurance process in place to maintain the competency? I actually wanted to share this. I know it's a really busy slide. You might not see it, but this is actually a clinical pathway for evaluating um, a patient with a possible DVT with ultrasound. So this is really for outpatient setting where you're first going to screen the patient by doing calculating their Wells score and then deciding, can they just be ruled out with a D-dimer? How soon can I get that D-dimer? Or can I perform point of care proximal um, ultrasound of the lower extremity, and if it's negative, it's ruled out in a low risk patient. Versus maybe you need to have a combination, or perhaps you do POCUS now and then have the patient repeat the study in 5 days to 7 days. So this is just something to think about. And by the way, this um, pathway is available on HelloSono's website. If you go to hellosono.com under resources, there's a part that says downloadable, so you can actually download this pathway. And jumping to provider credentialing. So what is the standard to ensure competency among the providers before they start using POCUS? So this is based kind of on combination of American College of Emergency Physicians and also AAFP standards. And remember, those are guidelines. They are not requirements, but maybe in the future they will become requirements. And this is obviously for US-based kind of providers. So typically it is recommended to have some kind of asynchronous learning. These days it's usually online. There are a ton of online courses out there that you can take. Some of them even come with question bank. Some of them come with CME. So there's a lot to explore out there. Typically, you want to have the providers do a hands-on workshop, or if you are a provider yourself, hands-on workshop is really, I believe it's essential, although you can do simulation and remote kind of virtual training. I think it really doesn't replace a hands-on workshop where you have an expert really telling you how to do it in real time and correcting your movements as well. After that, this is the next part is the one that takes the longest, and that's the preceptorship part. And really, the minimum recommended studies that you should be obtaining is 25 of each exam type. So if you're learning a lung ultrasound, you should be obtaining educational exams, 25 exams of the lung, and then having them reviewed by an expert, someone who already knows how to use ultrasound, so they can give you feedback on the quality of your images and also on how good you are at interpreting the images. So this part where you're doing this preceptorship, say you're learning 4 different ultrasound applications, this might take actually a while. So if you're learning 4 ultrasound applications and you're getting 25 of each one of those, right? That's 100 scans that you're performing initially just to develop competency because you're getting them reviewed. And that's once again, that's kind of the current standard. It's guidelines. It's not a requirement. And then it's a good idea to have some kind of assessment, whether it comes in a form of maybe getting a certification, the way the POCUS Certification Academy has their certifications, their online quizzes. If you're part of a bigger institution and you have someone on site who is a POCUS expert, they can actually do an OSCE style type of observation of a patient of a provider performing ultrasound at the bedside. And of course, a part of the credentialing is also how are you going to maintain those credentials? Will you, when you're writing your protocols, require your providers to perform a minimum number of scans every year to maintain their skill? That's an important consideration as well. And typically, you want the recommended number is to require 10 of each exam type. So 10 of lung exams every year, 10 of soft tissue exams every year, just to maintain the skill. And another thing to consider for maintenance is would you want your providers to also have some continuous medical education? So maybe every 2 years you have them, you require 3 to 5 hours of CME specific to POCUS, or maybe it's not CME, but something that they can prove that they watched maybe content related to POCUS. And what would be the purpose of credentialing the providers? One of the biggest reasons is you just want the providers to be competent in POCUS before they start making um, diagnostic decisions, right? And it just goes back to patient care. You want it to be great. It also offers medical legal protection, right? So say the provider misinterpreted the ultrasound, but they have completed the proficiency, the training to basically get proficiency in POCUS that's recommended currently by medical organizations. So that could be really protective in case there is a miss. And by the way, I don't want to scare you because actually the good news, there have been studies done on medical legal risk on POCUS, and it's super minimal. Um, Very rare to have POCUS kind of be part of a malpractice lawsuit. Usually it's not doing POCUS or delaying POCUS. That's the issue. It's not about misdiagnosis. And then the next part is, although currently um, the payers are not required, most of them are not requiring to have a certain type of training in POCUS before you start billing. It's heading that way, or they might review or audit you, and they might ask you like, "Hey, we noticed that you started billing for POCUS suddenly. What's going on? Are your providers trained to do POCUS? What is their certification?" So that is really a good reason, some really good reasons to credential providers and have a pathway for that. And then the last thing to consider in all of this is POCUS really financially viable for you and your practice? And there are a couple of things here to consider. Number one, consider the overhead costs. So do you have the budget? Usually the investment, if you're one provider, is probably around $10,000 to get the basic training, that preceptorship component, and also um, get the device and kind of the storage that you need to get this started. So that would be your investment, and then you might have some subscription costs afterwards to the software, for example. Um, and so another thing to consider is there profit in this for your clinic? So ultrasound does come with procedural CPT codes, and I'll share them in the next screen. However, do your payers cover those CPT codes? So the next thing you probably should do is take a look at your payer contract and see what's in there. Does that make sense for you to be doing POCUS? And a flip side at looking at this is also other cost savings in doing POCUS. So if you're in those capitated plans or in a value-based care models, can you save costs by avoiding sending patients to the ER, or maybe starting a more appropriate treatment sooner, right? So you're saving costs there, and can you show that to your insurers? So that could be another way to actually have revenue from POCUS, and that's by saving costs. So there are a couple of things I wanted to share with you here. If you scan this QR code, or you can just go to hellosono.com. We have a POCUS ROI calculator, and that's really filled with current CMS rates so Medicare, Medicaid rates, and they are global rates. So you're billing for both technical and professional component. That's the first calculator. So you really can just put in like, hey, how many of musculoskeletal exams am I going to be expecting to perform every week? How many lung exams? Um, and just put in this number, put in your patient mix, and it will give you an approximate number of um, billable amount basically per month and per year, so you can at least have an idea. The second calculator on there is more for practices that are part, kind of like they are the outpatient department of a hospital system where they are just billing the professional fee, not the whole global fee. And these are some CPT codes. I'm happy to email them to you guys as well, or they are also available for download um, in the resources section of the website. But these are the common CPT codes. So on the left is for the diagnostic CPT codes, and on the right are the procedural CPT codes. All right, before I go here, I'm going to check the chat and see because I'm ready to do the roadmap, but I want to see what's going on here. Uh, Q&A, there's one. Okay, this is pretty. There's a question about um, doing a POCUS fellowship. Okay. Um, I mean, there are fellowships available, and that's a really great idea. I don't have any like off the top of my head, mostly because my pathway for me personally was through emergency medicine. And when I was doing the ultrasound fellowships, they were only for emergency medicine trained residents or providers. But now there are fellowships available that are open to um, advanced practice practitioners, that are open to family medicine, obviously, residents and physicians. So there are plenty of options. I just don't have the specific kind of names for you. Thank you for the question. All right, I'm going to move on. The roadmap. Are you guys ready? All right. I wish I could see everyone, but I can't. So I'm just going to keep going. Okay. So what is the roadmap to implementation? I kind of broke it down into four segments. The first segment is doing your research, right? You got to do your due diligence. And questions to consider, is it clinically useful for my patient population? Are my providers on board? Are they excited to learn POCUS and commit some time to learning it? Is it financially viable? Do I have the budget to get started? And do I get maybe some profit, to make this a self-sustaining type of program financially? And the next thing to research is really what is available internally, right? If you are part of a bigger institution, see what storage solutions are being used currently, what devices are being used. Does your biomed or IT department have any preferences? And I'm giving you a little timeline, but take maybe a couple of weeks to do some good research, and maybe also talk to some of the colleagues in your state or in your town to find out how their reimbursement is with POCUS if you know someone who's using it. Next stage is preparation, and that's a really important stage for the implementation to go smoothly. So it's important to gather a team, right? And by team, I mean if you're in a bigger kind of clinic scenario, is having a clinical POCUS champion, right? Someone who really is going to be the go-to person, really believes in POCUS, and kind of knows the resources as well. And then by team, I also mean who else needs to be involved? So your IT, your biomed, and maybe you're outsourcing those things, but still bringing those people in together. Maybe your financial operations officer also needs to be involved. So figuring out the key people to be on this POCUS effort. The next thing you want to do is figure out what exam types, POCUS exam types, will be useful for the patients and confirm. I wouldn't start with more than four, probably. Four is a good number if you're completely new to ultrasound. And also confirm the learners, right? Are you going to train all of the providers or maybe only the ones that are really interested in doing it? And that's a great way to start as well. The others will follow, trust me. The next thing you want in the preparation stage is also kind of learn about the devices, figure out what features you want, and start picking the devices and the storage solutions. And there are a lot that goes into it. You might want to demo some of the solutions as well. And or maybe even go to a conference where there are a lot of POCUS device companies and you can just demo all of them at a conference. Next thing in the preparation stage is figuring out those clinical pathways and protocols. How is this all going to fit together? And I gave you some examples, but yeah, those infection control protocols and credentialing protocol are really important. And the next thing is figuring out the timeline. Right. So when do you have time to get started and your team? Because there is an effort from IT and biomed there. So make sure you're all on the same page. So I would say the preparation stage probably takes about 1 or 2 months. The next stage is really important. That's when you do the thing, right? So you're training and credentialing the providers and you're implementing the workflow. So what does implementing workflow involves? Well, first of all, it's customizing the actual workflow, figuring out how the device is going to talk to potentially the storage solution, how the storage solution is going to talk to your EHR if you are using one. So that's a good way. Or maybe you can connect the device straight into EHR. But those are kind of the options you have there. You also want to design the procedure notes in your EHR so it's quick to document. And a lot of times you want to include the CPT codes for your billers when they are billing for the chart. So in that procedure note, another thing to consider is also creating order sets in your EHR. Of course, you got to credential providers, so that's quite a process. And as we talked about in the prior slide, it might take 3 months to even a year, depending, how extensive the training you're going to be doing and how many ultrasound applications the providers are going to be learning. Figure out your QA process as well in the beginning. So once this is rolling, you're really keeping up with it. So once the providers are credentialed, who's going to do a little bit of QA? So about 5% to 10% of the studies should really be reviewed for quality to make sure that you can maintain that. And then my recommendation is to start billing after all of that is in place and your providers are credentialed. There's not really a requirement to bill after all of that has happened, but just a good idea in case there are some medical legal issues that come up that your providers are fully credentialed and the QA process is in place. So this part might take 3 months to 12 months. I would say the implementation of the workflow can take 1 to 3 months, but then the actual training can take up to a year. And then finally is measuring the impact of your POCUS program. So what you might want to measure patient experience and provider experience. How is that changing for them in their day-to-day practice using POCUS? What are your POCUS utilization rates? What are you using it for? Are you diverting patients from the emergency departments? Maybe there are some quality measures that you can be tracking that POCUS can impact. What's your throughput in the clinic or in your practice? Is it going a little bit faster? And then finally, the financials. So what is the reimbursement like? Are you getting a lot of denials? Those kind of things as well. This is the roadmap, and maybe I can make a little slide or share this slide with you later. But basically, 4 major steps. So research, preparation, training, and implementation. That's the one that takes the bulk of the time. And then afterwards is measuring that impact. I'm sorry about that. I'm assuming you can see this now. correct?
Yes, we see
Okay,
it.
yes.
Roadmap.
Okay, okay, great. Okay, thank you. So, some tips for success in implementing POCUS. Number one, have really strict clinical pathways, at least initially, especially if you have a lot of novice users, right? So, POCUS does have limitations. A lot of times it is the first step in diagnostic workup. Sometimes it's the only step and you're done, but sometimes you need to get follow-up studies, maybe a comprehensive ultrasound, maybe a CAT scan, right? So, figuring out what POCUS should be used for. For example, if you have patients who are older coming in with abdominal pain, right? Those patients in their 70s with abdominal pain should probably just be getting a CAT scan or going to the ER. They don't need to be getting an ultrasound in your clinic. So just having pathways like that, the one that I showed you with the DVT, would really help your providers who are new to POCUS to utilize it the best way possible and evidence-based way as well. I recommend always piloting first. So start with a smaller sample of clinicians, for example, or if you are at multiple sites, start with one or two sites that you think POCUS would make the most impact. And then also the number of applications, right? So keep it small. You can even start with two applications and see how it goes so you don't overwhelm the providers with the studies. Another thing to consider if you don't have a lot of budget, or maybe you have really poor access right now to getting hands-on POCUS education, there are other things that are available, including learning POCUS through SIM or teleguidance, or using more devices with AI features. So that's definitely also a possibility. And then finally, as I mentioned in the last slide, is really collecting data is really important. Because if you pilot something and you've collected data and you show that your patient satisfaction is improving, you're keeping patients out of the ER, you're maybe bringing some revenue, your providers love it, right? Then you get also the support from the administration to keep the program going and making it better and introducing other POCUS applications as well. So the key takeaways from this presentations would be really doing your research first, right? Does that make sense for my clinical, for my population? So identifying those use cases, and also is it financially viable for my practice? The second one is really ensuring that provider support. Make sure the providers are excited to learn POCUS and believe in it, and also understand that it might take some time to develop proficiency. And the rest of it is, I believe that credentialing the providers, making sure that they are competent and following the current standards, is really, really a good idea and really protective in the end. Make sure you're documenting exams, storing them, and measuring outcomes. All right, well, I'm pretty much done. So this is a QR code for the ROI calculator. That would really give you a sense more if you are in the United States. If you're international, that probably is not very useful. So I'm sorry about that. And then this is my LinkedIn, so please connect with LinkedIn. Let me know that you attended a webinar. I would love to keep connected, and we've been putting actually quite a bit of content out on LinkedIn with POCUS education as well. So let's advance patient care together. I'd love to hear from you and hit up some questions.
Thank you for a great presentation, Dr. Haverlook. We will begin the Q&A portion of this webinar shortly, so please leave any questions that you have for Dr. Haverlook in the Q&A box. Before we get into that, Dr. Haverlook has prepared a few quiz questions for you, and they will be on your screen shortly. Thank you for answering our quiz questions. We also have additional questions for you that you will see on the screen right after this one. This helps us to plan the next sessions and receive feedback directly from you. Please respond before leaving the webinar. We'll leave the screen up. All right. So for the number one question, what is recommended minimum number of scans that should be reviewed for quality to ensure competency in one POCUS application? Most people answer 25.
Oh my God, you've been listening. Good job. That's the correct answer.
For
25
number
is the minimum. Some recommend 25 to 50 exams, actually.
for number two, POCUS is a reimbursable procedure that comes with specific CPT codes, true or false. Most people answer true.
Good. And actually, I wanted to go back to the first question. Maybe it
Sure.
was a little bit tricky. So that was specifically for diagnostic POCUS exams. The answer is different for procedural POCUS exams. So you actually, for procedural, it's 5 to 10 exams. And you're considered competent because procedure is really the most important part of whatever you're doing, whether it's IV access or paracentesis. Ultrasound is really a very small addition. So, for those, you just need 5 to 10.
And then the last question, what metrics are important to track when implementing POCUS? And most people answered all of the above.
Yay, correct. All right, you guys have been listening. I'm ready. Quick questions.
All right. All right, we're going to now begin the Q&A portion of the presentation. We did have a few questions that were submitted prior, so I'm going to give those to you, Dr. Haverlick. What are some best practices for implementing quality assurance processes in a busy primary care setting?
You have a couple of options. So if you have someone internally who is, a really a pro POCUS user, so maybe someone who just had a lot of POCUS practice in their residency, or maybe they completed a fellowship, they could be the point person doing some of the reviews. And that's really once your providers complete the training, it's recommended 5% to 10% get reviewed for quality. If you're using virtual radiology, you could potentially send some of those for overread, although it ends up being a bit pricey to do that. And another option is using someone externally, like us at Hello Sono. That's what we do as well. We will review scans for an institution as well to ensure quality and give you a report.
Thank you. Next question. How can practices ensure secure and efficient image storage that complies with privacy regulations? For example, HIPAA.
So there are quite a few vendors now that have solutions for that. I think the biggest issue is really the price point of those solutions. There are some cloud-based storage options. I'm sure a lot of you guys are familiar with Butterfly. There's also EchoWorks, Talaxi QPath. They all do kind of cloud storage type of solutions as well. And it really depends. The subscription level determines of how much you can do with that subscription. Is it just for storage, or can you also do QA on that subscription using that subscription, and get, statistics on performance, etc. So that ends up having a higher price tag. But there are options, and they are all HIPAA compliant. There are other solutions that sit on your internal server of the hospital, the clinic, so they are not cloud-based. And there are also, the like old school stuff. Like you can technically export all your studies and put them on a hard drive and then lock them in the cabinet. I mean, we kind of have moved away from that, but that would be the least expensive way to do something like that. Um, and then also another option is to send them directly to PACS if you are using PACS for other things. Usually when you send it to PACS, you will have to have a discussion with radiology, like, hey, those are the scans that are POCUS, you don't need to review them. We need a separate storage within your PACS, so that might lead to some, negotiation with your radiologists.
Thank you. And last question that I have, how do you see the role of POCUS evolving in primary care over the next 5 to 10 years?
Oh my God. First of all, it's going to be everywhere. That's going to be
Yeah.
literally the standard. the new residents who are graduating, they are learning POCUS. The expectation is going to be using it on a daily basis in practice. Similarly, with NPs and PAs, those schools now also a lot 20 last time I read, a quarter of them are currently offering POCUS curriculums. So I really like with technology becoming less expensive, and all this kind of, now these educational requirements coming in, we will be seeing POCUS almost everywhere. And I think procedural POCUS is going to be big. I think screening for AAA, why wouldn't you do it in your primary care office for patients to qualify instead of sending them to an ultrasound? It's such an easy test. So yeah, great
Thank you.
question. I love it. I love the future. I also think there's going to be
That's
a lot
right.
more AI. So
Yes.
there's going to be a lot of AI assisted interpretation, and it already is happening. So right now there's technology where you put a probe on a bladder and it will tell you bladder volume. You put a probe on the lung and it will tell you like, hey, this lung is air filled. Hey, this
Mm,
lung is fluid
so cool.
filled.
Yeah.
So it's already happening. Uh,
Yeah.
yeah, it's gonna be
Focus
great.
is the future.
Yeah, it is the
Yes,
future.
it
I
is.
mean, I mean, honestly, probably we won't be having stethoscopes in the
Mm,
future once, maybe in 10 years.
right. Thank you. Well, if there are no more questions, I've checked the comments in the Q&A box. That concludes our Q&A portion of the webinar and our webinar. That wraps up our session. Thank you so much to our presenter, Dr. Tatiana Haverlek. A recording of this webinar will be made available on the pocus.org website in approximately 1 week, and you will receive a link via email. Thank you for attending our webinar today, and we look forward to seeing you on a future webinar. I will leave that last poll up, so please take your time to answer it if you haven't had the opportunity yet. But other than that, we'll see you at the next webinar. Take care.
Thank you, everyone. Have a beautiful day and happy scanning. I'm looking forward to a lot of POCUS in the future.
Thank you, Dr. Tatiana.